I'll get started while we're getting geared up here. And I provided slides not really to give a presentation, but for visual impact. So I'm Mariann Yeager. I'm CEO of the Sequoia Project. We are a nonprofit with a public mission, which is to really advance secure nationwide interoperability. We had a pretty unique beginning in that we were started back in 2012 to be a steward for an initiative which was started by the federal government. It actually was led by our very own John Loons, which he loves when I point this out, because then I can blame him, right? But it was an effort related to building a nationwide network, the Nationwide Health Information Network, and it was really incubated by ONC through a cooperative process with a group of 18 private sector organizations and 12 federal agencies, and that cooperative really developed what is now the underpinnings of what is now called the eHealth Exchange, which is really a shared trust agreement and rules of the road to enable all these different groups to share information securely with each other without a single intermediary. And it's really facilitated through a common legal agreement and a security model. The eHealth Exchange has grown dramatically since it's lived in the private sector by more than 5 times. I wanted to share this slide simply to share the statistics. The CDC was actually one of the very first participants in the eHealth Exchange. They were really facilitating I think it was a pilot at the time with Regan Street for biosurveillance data, and I think that they're pursuing sort of different avenues with that. But today it is the principal way that the federal agencies listed here share data and access data from the private sector. There are 180 nodes, so to speak, 47 of which are HIEs. But that really represents more than, it's probably closer to 70% of all U.S. hospitals, and you can see the other statistics, every CVS Minute Clinic, every Walgreens, every DaVita dialysis center, all 50 states, more than 100 million Americans. So I share that simply because this network exists to really support a multitude of purposes, and while it was formed initially to support the exchange of health information to improve care and care coordination, it is a network that can be extended to enable the sharing of information between clinical settings and social services agencies. And so we've actually had conversations recently, how can we extend and build on the existing infrastructure, this existing connectivity to support you? And so we've had conversations with United Way 211 programs, we've had conversations, can we support pilots to enable the sharing of data for opioid activities, and so I just offer that as an opportunity. So it's interesting because circa 2009, which is when data was first shared, it was very much in the nascent stages. There really weren't, there was not a high degree of adoption of electronic health record systems. And of course, as a result of the meaningful use in high-tech programs, we now have a high degree of adoption of electronic health record systems. So it's interesting because I think at the time this activity started, the thought was there would be sort of largely probably maybe a single nationwide health information network, but what has materialized in fact is a multitude of networks. And what has been really eye-opening is the important role that electronic health record vendors and other IT vendors and service providers are playing to facilitate the sharing of information. So today there are really more around, probably maybe a dozen or more data sharing networks. Some of them are national level in scope, and of course that doesn't include the 47 HIEs I mentioned, but there are increasing numbers of networks which are actually based upon technology vendors. So you can see Athena Health and eClinical Works, they have their own data sharing networks to connect their customers, and you can see others here as well. But there are also service providers that serve as either facilitators, intermediaries, or they provide record location services, for instance, to discover the locations where patients have received care. They play an important role. So when you think about connecting providers to a network, it took us 9 years to get to those statistics with the eHealth Exchange. But imagine connecting a network like the eHealth Exchange with these other networks, you reach a pretty phenomenal scale, and that's facilitated through a common trust framework and common agreement that interconnects those networks. I wanted to share these statistics again to show the reach. Care equality data sharing began July 1st of 2016. Within 12 months, there were maybe a couple hundred hospitals and about 1 million CCDs exchanged. These are the statistics as of the end of September. 4.5 million CCDs exchanged, up from 1 million in 3 months. This is the power of connecting networks, and there are significant rollouts planned. So the organizations listed here have all signed the Carry Quality Connection Agreement. They're in various stages of rollout, and there are others coming on board here later this year. Commonwealth is in the process of preparing to test, and they'll come on board in early 2018. So we have this massive interconnected country, massive amounts of clinical data being exchanged in an unprecedented pace. We are here to really serve as a foundation for your work. Please build off of what we have. We can easily extend what we do to support your use cases. We can easily expand the technical standards requirements. We already have the lion's share of the country's vendors and HIEs and providers under contract. It's easily extensible to support you. And so we just welcome any opportunity to do pilots. We're very innovative. We're not funded by the federal government. We're an old-fashioned startup. We can be very nimble and creative, and we just want to work with you. So that is my message today. So with that, I will turn it over to you.
Right on time also. Thank you.